Hello, I am Enrique Quesada, and this is Mexico Centered, a podcast from the Mexico Center at Rice University's Baker Institute for Public Policy. On July 1st, 2018, Mexican voters went out to the polls to elect thousands of public officials. Among these, voters participated in the election of all 628 members of Congress, 8 governors, a mayor for Mexico City, and the next president of Mexico. The president-elect, Andrés Manuel López Obrador, will take office on December 1st, and his coalition will enjoy majorities in both houses of Congress, which begin their term on September 1st. Immigration reform has been part of national political discussions for more than 20 years, with unsuccessful attempts to pass legislation that provides a so-called path to citizenship for undocumented immigrants. Recently, news broke that families were being separated at the border, and raids by the U.S. Immigration and Customs Enforcement, or ICE, are on the rise. Moreover, the Trump administration has also been vocal about and active in their opposition to the Deferred Action for Childhood Arrivals program, known as DACA. The undocumented population living in the United States is prey to many sources of potentially traumatic experiences. Not only might there be economic or violence-related reasons for these immigrants to leave their country of origin, but crossing the border presents many dangerous situations such as human or drug trafficking and extortion. In the United States, undocumented immigrants, including those who were brought here as children, live with uncertainty at every turn, from driving to work to accessing healthcare services. How does the uncertainty and traumatic experiences that this population faces day to day impact their mental health? Culturally, are there any differences in how this population understands and deals with traumatic experiences? And how can we take care of an undocumented population that desperately needs access to mental health services? To answer these questions, I sat down with Luz Garcini. Luz Garcini is a postdoctoral fellow in the Department of Psychological Sciences at Rice University. Garcini completed a combined degree in clinical psychology and epidemiology, with her dissertation focusing on the psychological distress among undocumented Mexican immigrants in high-risk neighborhoods. Her research is the first to provide population-based estimates of distress among this population. Here's our conversation. Luz Garcini, thank you so much for allowing me to come here and talk to you. I'm really looking forward to this conversation.
Absolutely.
So you're a postdoctoral fellow in the Department of Psychology, and you are studying the undocumented immigrant populations here in the United States, particularly the ones that come from Mexico, and how this traumatic experiences that they may have experienced either on the other side of the border or on this side of the border while undocumented affect their mental health. Mm-hmm. And I think that when we think about the position that undocumented immigrants are in, it seems obvious that it would be a very, if we think about it a little, it seems obvious that they would experience a lot of very, things that would cause an anxiety. Just mm-hmm. the status of not being protected legally, really, if anything happens to you, just having to constantly worry about mm-hmm. being here in the United States. Given something that seems obvious to a lot of us, what's the state of research in this area?
Very interesting question, and thank you for your interest. Actually, we have a lot of documentation in terms of specific cases that have been taken to the court system, in terms of violations to human rights, in terms of deportations who have separated families. We know from the media about a lot of interviews as to how this population experiences distress, and the negative consequences that it has, not only for the mental health, but also for the physical health, because this is a population also that lacks access to health services. However, no one has ever put a number in terms of epidemiological approaches in terms of a percentage. So how can we compare ourselves or these populations to any other populations and determine what is the extent of the damage, what is the extent of the change of the trauma that this population experiences? And as you probably know, in political science, numbers is what moves policy and moves advocacy efforts. So I think we need both. We have a lot of qualitative data that it's supporting the distress that these immigrant communities experience it. But more importantly now, we're working on numbers. And finally, we have the first estimates for to give us an idea.
So the research that has been done supports this idea that we have that, of course, they're experiencing this distress and emotional distress because of all this traumatic experience that they have and all this anxiety they live in. But quantifying that hasn't really happened yet, or it's starting to happen, right? That's the research that you've been working on, actually.
Yes, now we have a number. And, and this is, we get to this number by using certain techniques that allows us to get to, a variation of randomized models to collect the data using population-based estimates. And,
this is a specific population that's difficult to study.
Yes.
Because they want to remain hidden.
Yes, this is a population that is hidden or hard to reach, so it's definitely very, very hard. And actually, the last study that I did is very different to the current study that I'm doing because of the changes in the socio-political climate that we're living. So in order to be able to do my study back in 2014 under the Obama administration, and most of it I conducted it in California, I had to embed my system, myself within the community for probably about 2 years before starting, so that the community will know me, so that they will trust me particularly. And then people started talking. And then that's how I started learning about the process. I had to do a lot of adjustments to what I thought was the ideal research protocol, because the community and these immigrants are the experts in who they might be willing to talk to, why they might be willing to go through. Even when you sit them down and put them through your clinical interview, because a lot of the time they're going to disclose very sensitive information that when you're talking about trauma, it's almost like you can experience a rush and reliving the experience. So then, as mental health professionals, it's like, what do we do when we open a Pandora box for something to talk about very, very severe and distressing trauma, and we cannot refer them for services? So it was a lot of learning in the process, and we got those estimates, but currently, I am doing a new study with actually the younger undocumented immigrants. A lot of them are DACA recipients, and I can see that the context is so different. People are
This is under this new context after
yes.
after the Trump campaign in 2015, 2016, and then now the new Trump administration.
Yes, people are terrified of talking. They will go and talk to me. They will not give me data. So I'm working on new methodologies, on new strategies to try to get something and educating our community to tell them how important is their voice, because it's the only way we can learn. But however, to answer your question, going back to the estimates that we have, we know from that data that I gathered in 2014, which it's important to emphasize it was a different socio-political context. The prevalence for having experienced one type of traumatic event, any type of trauma, regardless of it, and I'm talking severe trauma, was 82%. So if you really think about it, only 18% of undocumented immigrants, the majority of who were living in well-established families within the United States, they have lived here for more than 20 years. Most of them were families of mixed status. What it means is at least one member is undocumented, but the other members may have U.S. citizenship or legal residence. And only 18% did not have trauma. And that's not even talking about repeated exposure. So that's just talking about experiencing any trauma. Because when you actually look at the different types of trauma that they have experienced, we had a range between 3 and 19 different types of trauma. And that's not even talking, again, about if you experience, for example, rape multiple times, which is not uncommon among these women, that, a lot of them have experienced 3 or 4 times or 4 rapes in their history.
So what is so that's the kind of the amount of this population that has experienced this traumatic events. What's their relationship to mental disorders or this types of anxieties that they experience? You said we're trying to see how this population is different from the population at large?
Correct. Well, the several things come to mind, when we're talking about this. But one of the first things that was very intriguing to me is when I conducted the clinical interviews and I started analyzing the results, I found that the prevalence of post-traumatic stress disorder in this population was very low. It was less than 3%. And when you think about that, I started kind of wondering because it's like, well, they're not necessarily exhibiting symptoms of trauma-related distress as we know it in the United States, but they have a really high prevalence of trauma. So what's happening? And so I said, maybe we're not assessing trauma in the same way that it presents with the majority of the populations, or at least the populations for which the diagnosis of post-traumatic stress disorder was developed, which is primarily a Western view, among Caucasian military personnel. So our culture might develop it in very, very different ways. It's important to emphasize that it's a very resilient population, so they're very strong and they endure a lot. However, we know from the acculturation literature that the longer they are living in the United States under such chronic stress and bearing their trauma inside, the more likely they're to exhibit distressing symptoms. So what I did when I couldn't find that match with post-traumatic stress disorder, I look at another way of distress. So I use a clinical measure that allows you to capture symptoms, and it provides you a global measure of psychological distress in terms of symptoms along 9 different dimensions. For example, depression, anxiety, interpersonal sensitivity, hostility, and things like that. And our estimates went way higher there. So we found out that associated with trauma, about 40% had experienced clinically significant levels of distress. And it's important to emphasize clinically significant because what that means is those are the immigrants that they will be actually in need of having access to services. So they are in need on treatment, but they don't have it.
So how does culture play a role in this? Because you're saying, well, maybe these populations experience anxiety in different ways. And in reading some of the material that you sent me, you use the term ataque de nervios, which to me sounded very similar to, in English, panic attacks, right? Mm-hmm. But also in thinking about it, I don't think that's how we use it in Mexico. That's how we understand that. And so... And you're saying it was a challenge to kind of translate that, right? Like you have to look at a different thing to assess the amount of anxiety or the problems in mental health that this population might be facing.
Yes, absolutely. That was a very eye-opening experience for me because when I was trying to assess distress in a way that is cultural and context sensitive with this population, I traveled to Tijuana, to the migrant shelters, because I wanted to see if our measures would work. And, the best way was to test it on their undocumented immigrants or recent deportees who are on the most stressful conditions. And those were the recent deportees because it's very devastating to see, when they are dropping the border with nothing, even their documents are taken away from them, so they become undocumented in their own country. They're under extreme stress. And so I started asking questions, describing anxiety and describing depression, and I could tell that they were not understanding what I was asking, even though I tried to rephrase. However, the minute I said nervios, have you ever experienced nervios, which is kind of like an anxiety-like type of symptoms with a little variation, everybody understood what it meant. And I think it's because we are so used to contextualize it within our culture. It's embedded in the context of what is happening to a person. So it takes a lot of, it becomes more socially acceptable to have nervios. It's not necessarily attached to a mental health diagnosis that will make people think that you're crazy.
Right. The stigma, I was going to say that, yeah. I mean, even though here in the United States there's still some stigma about mental health in the Mexican population and even just Latin American populations at large, the stigma is quite higher. You don't really want to be associated with that
Yes.
Right? And so it also becomes more difficult.
Absolutely. That was actually, before I did this study, I did a lot of formative research with this population, and one of my questions was about the stigma of mental health. And one of the things I said, what is the term that we use when we talk about distress? And I said, what about mental health? And the first thing they say, oh no, that's cosa de locos, which means those are things that are for crazy people. And I said, okay, what would be a more acceptable term that we could use to try to, approach our services and call the attention of these immigrants that they could join us in prevention efforts? And they say well-being. So bienestar. So if we approach it from the side of well-being, we might be more likely to gain access and destigmatize, that association that we have with anything that has to do with mental health, which is associated with crazy connotation. Another thing that is particularly important with our population is somatization. So what that means is distress is manifested through physical symptoms in our body that are not necessarily explained through our medical conditions, but, you see them. They complain about headaches, stomach aches, sensation of crawling in your skin, feeling of cold sweats. So all of these symptoms are more culturally acceptable as symptoms of distress. Rather than accepting that a person is experiencing depression or anxiety, particularly if we consider gender differences.
So just to finish this point, and we'll move to another question, but I thought there's also this idea that these mental health problems, are a thing of Americans, right? Like there's also this sense that, that's a problem that Americans deal with. We don't. So there's also that other stigma of saying, no, we don't. That doesn't happen with us. It happens. It's just a different way that it happens because of the context and the language that we use.
Correct.
So what's the difference between this population and how they experience this anxiety, and then the population at large? Because I read one part that I thought was interesting, that when you talk about substance abuse, there wasn't a difference between this undocumented population, even under all the stressors, when compared to the population at large. But there was some other differences in other areas.
Right, absolutely. And substance use is one that I would love to talk about, particularly because under the current system, we have heard a lot of making reference and association for substance use and drug abuse and drug dealers with this population. And we know from my estimates that the prevalence of substance use in this population was the lowest compared to even their Latino documented counterparts or even their U.S.-born counterparts. So I went back and I asked, using focus groups to this population, how come it's not so much of a relevant problem, or how come the prevalence is so low? And they gave me two reasons that I was like, I totally understand this. So the first one was like, well, first of all, if we drink and use drugs, we cannot work at the level that we need to work. So there's no way that I can be drunk, wake up the next day and do 2 or 3 shifts in the fields under the sun, and still continue to survive. It's just not feasible. And they're here for economic reasons, the majority, or to be reunited with their families, to be able to provide for their families. So if they fail at that, they will fail at the reason as to why they came here. And the second one was very simple. It was like, if I drink or I use drugs, I'm going to let my guard down. So they're more likely to get me. So it's like I live in the shadows. I need to hide myself. So I would increase my chances of being caught on the border just by using substance use. I'm not saying that it's not there. It's just not a primary problem, and definitely not at the level as to what this population has been accused of.
And definitely not differently from other kinds of populations.
Actually lower prevalence than other populations in the United States.
So the population that you've studied, is it mostly people who came here as children, basically what we would say are the dreamers, that kind of population? I'm thinking also, if we think about other immigrant populations, that there's a lot of, from a methodological view, I was thinking there's all kinds of trauma that these undocumented immigrants can have experienced, either because there's some trauma in their families already, from their family, whatever their situation was in Mexico. Maybe it was poverty, maybe it was violence that made them come and not already come with some trauma, and then the experience of crossing the border, and then the experience you add to that of being an undocumented immigrant under, just you cannot let your guard down at any moment. You also, all the national discourse there at the center of that, and you had all of these stressors, and it's just. But anyway, there's difficulty in studying what kind of traumatic experiences we're talking about, whether they happen here, whether they happened crossing, whether they happen back in Mexico.
Yes. Well, my first study actually got a representative sample of different age groups. So the beauty in that it allowed me to compare different age groups and assess within undocumented immigrants who were most at risk. Sadly, you're right. I found out that those most at risk for mental health distress, and including the highest risk of substance use, even though overall the substance use rates were very low, were undocumented immigrants who were between 18 and 25-year-olds. So when I went back and started looking at the characteristics of them, a lot of them, they were brought as children by their parents. A lot of them are highly educated, at least they have touched some college. So when you think about it, that represents our dreamers, our DACA recipients. And then I started going back and digging a little bit more, and this is the population that experiences most distress because they don't see themselves different than their U.S.-born counterparts. This is their country. Right. Many of them don't even speak fluent Spanish. Their first language is English. So it is very hard, when you are educated, when you understand your position, and when you know you're not wanted here. And when you know your future is going to have a limit, because when you finish studying, you cannot work. And now it's even worse, right, when they're living the uncertainty of what's going to happen to them. So definitely they are the ones that are most at risk. I'm not saying that we shouldn't pay attention to the entire population, but they're definitely the ones that are at the highest risk. The other thing is that overall, when I look at the big picture what are these prevalence estimates telling us? They're mostly representative of family environments, of people who are living in mixed status families, of people who are well established in the United States, who have been here for longer than 10 years. So I'm not talking about the recent immigrant or the single immigrant. The majority, more than 80%, are parents with an average of 3 children. So we need to think about the context of these families and the fear. And we know from research that trauma passes on to future generations. So there's definitely a need to address something. Another very interesting point that you mentioned was that my sample is mostly representative of Mexican immigrants. I do have some numbers for Central American immigrants. However, the location where I conducted the study, the majority is of Mexican origin. This is why, I'm starting to look at other places. And I had to separate the data because the trauma that comes, particularly from undocumented immigrants that come from Central America, is much higher. Because we know the political violence and crimes that these countries experience for years and years and years, in their home country, and they continue to do so. And, we talk about the Mexico-United States border as being brutal, but if you want a brutal border, try the one between, Mexico and Central America. So these immigrants, just in the process of having to cross that border and then having to cross Mexico, particularly under the conditions right now with the cartels, a lot of them fall prey to them and have to work for them for several years and experience trauma before they can even make it to the United States. So I think that's a different population, which is definitely of concern, because if you think about it, how high the prevalence is for a Mexican origin population, imagine how much higher it must be from other populations who come with a history of political violence.
Yeah. So to come, I guess, to the end of this and looking at how can we take care of these populations? What do they need? What can policymakers do? There's the stigma of mental health, but what ways? How can we make them seek that help? Or are there any organizations that do this already? And I'm also thinking about policymakers, because how do you address? How do you take care of this population that is already at the center of a conversation? They're not wanted.
Yes, absolutely. I have to say there's always something that you can do. So the approach that, well, they're undocumented and there's nothing we can do is wrong. There is a lot that we can do, and we have something very beautiful in our culture and in other groups that are supporting us, which are community-based efforts. And I have to say they are the way to show our support to these immigrants. So it can start in the faith-based organizations. A lot of the churches and religious leaders have taken the lead in this. So they are organizing groups to provide them at first with education. So maybe it's not necessarily the traditional way in which we deliver mental health services, but what about maybe sitting down and explaining to them why, what happens to them changes the way they feel or affects the way they think, and what are some of the ways in which they can protect their mental health, which we can do a lot of behavioral strategies to teach them without having to attach a mental health label to it, but more in terms of prevention and health promotion. So there's definitely a lot that can be done. Advocacy organizations have also done a lot of great work. For example, not too long ago, I was doing a campaign to disseminate 10 key points to protect the mental health of undocumented immigrants with United We Dream, which is one of the biggest and largest advocacy organizations for DACA recipients and dreamers. So there's definitely a lot to do. Are there enough of us doing it? No. Do we need more funding to get this done? Yes. Do we need, and this is another one, do we need help from our community, from our undocumented immigrants as researchers? Yes, we do. Because without them, we cannot produce research. And I think that's on my side. That's one of the barriers that I'm having right now, that people are afraid, and it's absolutely understandable that they're afraid within the current context.
So are you hopeful about the future of not only this field as a field of research, but of what this research can do?
Absolutely. There's always hope. And if anyone can show us hope, is these immigrants. Like I said before, this is a highly resilient population. I would say the strongest people, because when they made the decision to migrate, it was the dreams and that drive that made them come. And I think it's going to keep them fighting and trying to figure out ways to make it better. I think there is a lot as researchers and as clinicians and as providers that we can do for them. I think it's a sense of social responsibility for all of us who came immigrants. I'm an immigrant myself. To give back to the community and to work together in ways that we can push it forward. Because again, like I said, the undocumented experience not only affects the immigrant who doesn't have a visa or who's in the process of getting it, it affects every one of us who loves one of them or who's embedded in a family who has one of them, and the communities that also benefit from them, such as employers. I know a lot of, Caucasian employers who are very good to their undocumented workers, and they realize the value, and they say, we can't do anything without them. No one will work the way they do. So I think we need to join efforts with a lot of these people to kind of put a voice together and help our immigrants overcome the challenging times that we're living.
Luz Garcini, thank you so much for answering this question.
Thank you.
That was Luz Garcini. That is it for this episode. Thank you for listening to Mexico Centered. Thanks to Lisa Huaqueta, our program manager, and to Tony Payan, the director of the Mexico Center at Rice University's Baker Institute for Public Policy. You can visit our website at bakerinstitute.org/Mexico and check out our Elections Resource Center. Views and opinions expressed in this podcast are those of the guests and the host and do not necessarily reflect those of the Mexico Center. If you have any comments or suggestions, you can email us at mexicocenter@rice.edu. We would love to hear from you. Mexico Centered is available on Apple Podcasts, Google Play, Stitcher, and Radio Public. You can subscribe through your favorite podcast app to receive all of our new episodes directly on your phone. I am Enrique Quesada. I will see you next time.